So tonight's video is going to focus on joints. So joints are going to help allow for movement within the body by breaking up the bones, right? We've talked about this before. If I had a long bone with no break, there's no way I could move that, right? But as soon as I create a break in the bone, now I can create movement. So the joints allow for movement, and they are actually, because they are these spaces between the bones here and where the bones come together, they actually help hold the bones together. And we're going to be focused on bunches of different types of joints and looking at some examples of them. And once again, lots of vocabulary. So there are two ways that we can classify joints. We can classify them functionally or structurally. And we are going to start with the functional classification of joints, meaning basically we're going to classify the joints based off of how much movement that they allow. So our first functional classification of joint, again, the amount of movement it's going to allow, is going to be a synarthrosis. Okay, arth right here, that's the joint. Okay, so a synarthrosis is basically immovable. Okay, there is very little, if any, movement at all in these joints. And when we mean movement, we just mean like the bones can shift a little bit if there's any kind of movement there. So synarthroses are immovable joints. They are important for shock absorption, and they are also called fibrous joints. Okay, so immovable joints, good for shock absorption, okay, also called fibrous joints. So make sure you're getting all your vocabulary, right? And some examples of these would be the sutures of the skull and what we call a syndesmosis. Okay, so the sutures of the skull, these are things like your coronal suture, your squamous suture, those sutures that you have already looked at. Okay, this is where we've got these sheets of bones coming together. You can see the suture right here in this picture on the right. Okay, and they're held together by fibrous tissue. See this dense fibrous connective tissue? That's why it is called a fibrous joint. So this synarthrosis is also called a fibrous joint because the two bone ends are held together by fibrous tissue. And so what will happen with these sutures is over time, this fibrous tissue here is going to ossify. And when it ossifies, right, it turns into bone. And so that would account for that immovable part, right? You're not really going to have any motion there between these two bones. Our second example here is a syndesmosis. A syndesmosis is held together by a dense fibrous tissue band. Okay, you can see it here, this interosseous ligament. That's a big, huge band of fibrous tissue. And so there's very limited movement with a syndesmosis, not completely immovable, but you're talking just like almost like a squishing feeling type of situation here. Very limited movement here. Some examples here would be the coracoacromial joint. So basically a joint in your shoulder, near that joint at the tip of your shoulder. Okay, and then the distal tibia and fibula. You can see the band, the fibrous band down there holding those together. Okay, so again, things we need from this slide, right? Synarthrosis, which is a fibrous joint because it's held together by this dense fibrous connective tissue. These are basically immovable joints that are good for shock absorption. Two examples would be sutures and syndesmosis. And I find a suture in the skull, and I find a syndesmosis at the end of the tibia and fibula, which means I'm also going to find it at the end of the radius and the ulna. So next up, we have an amphiarthrosis. Again, arth is a joint. Okay, again, we're still on functional classifications of joints. So an amphiarthrosis is going to allow for slight movement within the joint. These are also called cartilaginous joints, okay? Because these joints are held together by but sometimes usually by fibrocartilage, but they're held together by cartilage. So we had the synarthrosis, which was also called a fibrous joint because it was held together with the fibrous tissue. And now we have an amphiarthrosis, which is also called a cartilaginous joint because it's held together by cartilage. Okay, your examples here, we have symphyses as well as synchondroses. So symphysis joint is going to be a joint that's going to have basically two types of cartilage associated with it. It's going to have a thin layer of hyaline cartilage, and then there's going to be a large, basically pad or a disc of fibrocartilage between it. Okay, so almost like a sandwich of hyaline cartilage, basically touching each side of the bone. So there'd be hyaline cartilage here, and then the pad or the disc of fibrocartilage in between. You can see that also down here at the pubic bone joint, the pubic symphysis. Okay, that's why it's called the pubic symphysis. Right, there's the pad of fibrocartilage in the middle, and then the two discs of hyaline cartilage on either side. So again, some examples of symphysis joints would be what you see here, these intervertebral discs, as well as again the pubic symphysis. So small amounts of movement at these joints, okay, that are held together by cartilage here. A synchondrosis is going to be held together by a thin layer of hyaline cartilage only, so no fibrocartilage associated with this type of joint. Okay, some examples here would be that epiphyseal plate, right? Before it becomes an epiphyseal line, that epiphyseal plate is made of hyaline cartilage, as well as the sternocostal joints. You can see the example down here at the bottom, right? Sternocostal joints, so the ribs. Okay, so we've got these two types here as well. So again, amphiarthrosis, cartilaginous joints, slight movement, two examples being symphysis and synchondroses. Symphysis will be basically like a fibrocartilage sandwich, and a synchondrosis will be hyaline cartilage only. So next we have our diarthroses. Diarthroses are also called synovial joints. Okay, these joints are going to be freely movable. When we think about a joint, like a typical joint, elbow, knee, wrist, these are the kinds of joints that we are thinking of. These are freely movable synovial joints. They have a wide variety of parts. Okay, so they have the articular capsule, which is going to be lined with the synovial membrane. So you can see the capsule here, which is kind of right here, kind of holding things together, holding the joints together. And that capsule is lined with the synovial membrane. The synovial membrane is going to be important because that synovial membrane is going to release synovial fluid. Synovial fluid is going to act as a lubricant within the joint, so it will help keep the ends of the bone from rubbing against one another. This, you'll notice right here, it tells you that your joint cavity, so this area right here, is going to be full of synovial fluid, so that again it reduces the friction between those joints. So the synovial joint has the capsule, the synovial membrane that's secreting the synovial membrane, and they usually have bursa and tendon sheaths associated with them. Okay, so there's bursa as well as tendon sheath. So because these joints are so mobile, okay, and you've got tendons, ligaments, muscles that are crossing these joints, you run the risk of fraying those soft tissues, right? Every time this joint moves back and forth, the soft tissue is rubbing or possibly getting smushed between these different bones, and we want to keep the tendon or the ligament or the muscle nice and strong, right? We don't want it like an old rope, right? Like starting to fray and break apart. And so we protect it with these bursa and these tendon sheaths. Okay, the bursa, the tendon sheath, you'll notice both of them, they're the same structure there. They are synovial, basically synovial membrane sacs, right? So they're full of synovial fluid. So they're these like sacs made of the synovial membrane. And again, synovial membrane is going to secrete synovial fluid. And so it basically just wraps and protects the tendon sheath, protects the tendon. The bursa, you can see here, is keeping this ligament from getting smushed between the two bones. Okay, and they're just going to help protect the soft tissues associated with the joint. Okay, so let's look at some more specific structural classifications. So we were covering both functional and structural classifications. Functional being the amount of movement, synarthrosis with that very little to no movement, amphiarthrosis with some movement, diarthrosis freely movable. We were also talking structural classifications as well, whether it was a fibrous joint like the synarthrosis, a cartilaginous joint like the amphiarthrosis, or a synovial joint. Okay, and so let's look at a few more types of synovial joints. Okay, the structure of the joint is going to dictate what type of movement that the joint will be able to do. And so some examples of joints that we have here. The first one is called a plane joint. It is also sometimes called a gliding joint. So a plane or a gliding joint. In these, that articular surface, articular is where the two bones come together, that articular surface is basically flat. You can see this example here. Okay, so that articular surface is basically flat, so it allows the bones to kind of slide across one another. Okay, a common example here is your carpals, which are those bones in your wrist. Okay, if you kind of move and adjust your wrist right now, you'll kind of feel those bones just kind of sliding around just a little bit. That's what allows you to get so much motion within your wrist and within your hand. Okay, in addition to the carpal joints, you've got the ribs as well as the tarsal joints, because our hands and feet are basically built the same. Okay, and then if you remember those facets on the vertebrae when you were looking at your axial skeleton, those vertebral facets are basically flat as well. So all examples of gliding or plane joints. Our next one here is a hinge joint. So with a hinge joint, you have one convex and one concave surface. Okay, and so you'll see how these two fit together nicely. Okay, we have the one convex and the one concave surface. And so what that does is it limits the motion in one plane. You'll see on the gliding or the plane joint here, you can kind of go all different directions here and in all the different planes, X, Y, Z. Okay, with this hinge joint, I only get motion in one plane. Okay, and so an example would obviously be our elbow. Right, our elbow is a hinge joint. I can't rotate it. I can't wiggle it side to side. It just it will just go. It will just bend into flexion and extension. Also, you've got the talus and the tibia, which is actually a big part of our ankle. Can only go back and forth. And we'll clarify some of this and just look at some of this stuff in class, where I know it will make a little bit more sense. Okay, as well as your knee, obviously. Your knee is a modified hinge joint. Okay, it does sometimes allow for a little side-to-side wiggle room. Okay, our next one is a pivot joint. So a pivot joint is going to do exactly that. It's going to pivot. It is going to allow for rotation around one particular axis. So either around the x-axis, around the y, around the z, but I get rotation only around one axis. Okay, and so example here, you can see the radius and the ulna. Okay, that's actually how you get quote-unquote rotation within your elbow. Okay, is in that radius and ulna. C1 and C2. Remember the dens, the odontoid process that sticks up from the second cervical vertebra. Okay, the first one is able to rotate around that. And again, like I said, I will show you these in person in class. Okay, so our next set, we have 6 in total that we're going to look at. Okay, so our next set here is what we call a condyloid joint. So a condyloid joint is very similar to a hinge, but basically not quite as deep. I've got one convex and one concave again. But if you think back to what we saw before, right, with a hinge, it was really deep. Okay, this one is not so deep, so it's more, it's like an in-between a hinge and a gliding joint. You find this condyloid joint. Okay, this allows for motion in all kinds of directions. Okay, we can flex and extend. So basically what we think of as bending, right? So I can flex and extend. I can do abduction and adduction, which is moving things away from my body and towards my body. And I can do what is called circumduction. And we'll talk about what circumduction is again when I can show you in class, and I think it will make a little bit more sense. If you, you can kind of figure out what it is right now. If you take your finger, right, take your index finger and put it straight up in the air and spin it around. You'll notice your index finger, it doesn't rotate, right? It doesn't spin, okay? It doesn't spin like this, right? It doesn't rotate, okay? But it makes like a big circle, right? Where the tip of your finger, like a cone, the base of your finger stays in one place and the tip makes, so the base of your finger stays in one place and then the tip is what's going around in a circle. That is circumduction. Okay? And so these condyloid joints allow for that. So they don't do any actual rotation, they just allow for that motion. So your finger, okay, would be a great example of this. That metacarpal phalangeal joint, I'll spell that, metacarpal, so basically your hand to your finger, metacarpal phalangeal joints. And again, in your feet as well, metatarsal phalangeal joint. Okay, those allow for that circumduction. Okay, next we have a saddle joint. Okay, a saddle joint, they are both surfaces are arched up like a saddle. Right, so I have both surfaces that are shaped like a saddle. It allows for the same motion as a condyloid joint, so that circumduction, the flexion, the extension, abduction, adduction, just on a larger scale. We get even greater range of motion, and this is important for our thumbs. This is where we get those opposable thumbs. Okay, and our last one here is a ball and socket. Ball and socket allows for the most motion. Okay, it does sometimes sacrifice stability for motion. For example, shoulder and hip are our two big ball and socket joints. Okay, hip is much sturdier because the socket is much deeper for the head of the femur to sit in. Shoulder, not so much. The socket is barely concave, and then the head of the shoulder sits in that joint there. But it allows for rotation in all 3 planes. Okay, so it allows for the most motion that we can get out of a joint. Okay, so I know that hit you with a ton of vocabulary at one time. So again, just practice with that vocabulary. Okay, we'll do some Quizlet, Kahoot type things, to help you practice with it. We are not going to spend a bunch of time on injuries. We're going to really kind of hit the high points and move through those pretty quickly. So first injury, most of y'all have probably had it, is a sprain. Right? A sprain is basically it's not a dislocation, so it is different. The joint has not come completely out of socket. Okay, you have damaged the soft tissue with a sprain. Okay, with a sprain, you basically have overstretched the ligaments. You can see that happening here on the outside of the ankle. This is our most common sprain, an inversion sprain. Okay, and there's an overstretching of the ligaments there. possibly result in tearing of the ligaments, but hopefully does not. Okay, and can sometimes be actually more difficult to heal than a regular, break of the bone because of the healing time that's involved in those soft tissue injuries. Treatment for a sprain is obviously going to be rest, okay, and ice it to bring down the swelling. You can do some compression, okay. You can also put in some passive motion and stuff to try to move the swelling out of the area, okay, but then basically just giving it time to heal. Okay, so a joint dislocation is definitely a step up from a sprain. With the joint dislocation, you can see here, right? And then here is the dislocation. The joint has become completely separated. Okay, the two ends of the bone have become separated and they are no longer lined up anymore. Okay, so you're going to have soft tissue damage with this. Okay, and the soft tissue damage can actually sometimes be so severe it makes it difficult to return the bone where it belongs. For example, the shoulder dislocation here at the top, if that is not put back in almost immediately, it usually requires surgery to put it back because the amount of soft tissue surrounding it will seize up and you cannot get the bone manually back into the socket. You can see here, this is an elbow, right? This is supposed to be over here. Okay, and so this elbow has been dislocated, so we would need some traction and we would need to shift it back under and line it back up with the humerus. You can see here their knee has been dislocated. Okay, so with the dislocation, obviously you need to reset the joint. We need to get the bone back in place. And then after that, as a general rule, it is just soft tissue healing time. You may have damaged some of the articular cartilage here on the ends of the bones, okay, but that actually doesn't usually show up as painful or as an issue until later down the road as more of an osteoarthritis setting in. Okay, bursitis, the itis here, lets you know that it is an inflammatory injury. So this is an inflammation of the bursa. Okay, it's usually due to repetitive use, okay, repetitive movements. You can see there's a big inflammation, big swelling there on the back of the elbow here. This is in front of the kneecap. Okay, there's a bursa there, and so that is irritated and swollen, and so it manifests as basically as a lump. There usually be some redness. Again, treatment for these would be resting it, as well as stopping that repetitive motion, and whatever motion is causing that bursitis, so that it doesn't return. Okay, let's look at some types of arthritis, and then I think we will be all set. So our first one here is rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disorder. So an autoimmune disorder, okay, is your body is attacking itself. So your immune cells are having trouble recognizing your body, and so they start attacking your body. So we get a lot of inflammation with this. And what will happen, if you look down at this diagram on the bottom here, you can see the synovial membrane starting to thicken up. Okay, and as that synovial membrane thickens up and the articular cartilage here, that cartilage at the end of the bones, starts to break down, this becomes very, very painful. Okay, basically your cells, your immune cells, are attacking your joints. And so they'll attack both sides. So you'll notice this looks like a female to me. Okay, you'll notice it is bilateral, so both sides are affected. Osteoarthritis doesn't have to be bilateral. And a lot of times rheumatoid arthritis, when it becomes very severe, will result in deformity because of that thickening of that synovial membrane and the breakdown there of the articular cartilage. There is not really a treatment for this. Again, it's an autoimmune disorder. It's more of a management, really trying to bring down the inflammation. It can be managed sometimes with medicines, anti-inflammatories, things like diet can help manage this because you can eat an anti-inflammatory diet. So there's a lot of things that can be done to try to help manage it And patients with, as with all autoimmune disorders, kind of have to figure out, learn about all their options, be presented with a wide variety of options, and then they have to kind of figure out what works best for them. Okay, our last joint injury here is osteoarthritis, bone, a non-inflammatory. So this is not a big inflammation issue here. This is not autoimmune. This is a degenerative, so a progressive over time degenerative disorder of the articular cartilage. So basically what happens is over time, this is the arthritis you get with old age. Over time, right, the articular cartilage starts to break down, and that becomes painful. It causes swelling. There's stiffness and trouble. ROM is range of motion. So we start to lose some of the range of motion there. Usually when a patient with osteoarthritis rests, the pain will decrease, but sometimes the stiffness will increase. So they have to kind of find a balance between enough motion so that they don't get too stiff, but not so much that it's very painful. If you look at the x-ray here, you can see there's a normal knee, with nice healthy articular cartilage on the ends of each bone. And then you can see here this breakdown of the articular cartilage. And now the ends of the bone are touching and rubbing together, and it becomes very, very painful. Again, you can see that in the diagram over here. Okay. So again, I know we hit really heavy in the beginning on vocabulary, but injuries we didn't go too deep in, so you can spend a little bit more time focusing on that vocabulary. And we'll look at some things that hopefully will help you kind of wrap your brain around the vocabulary in class.